This video is a guide to the peripheral insertion of central catheters under aseptic conditions. The guide focuses on the creation and maintenance of aseptic conditions throughout the procedure, with the emphasis on the team approach and ensuring that the catheter tip is in a safe position post-procedure by the use of X-rays with or without contrast. Before you begin, there are a number of tasks to perform. Always inform the parents that you are planning a procedure on their child. Agree on a time to perform the procedure in keeping with the principles of developmental care. Wash your hands and examine the baby for an appropriate site for insertion of the line. Make sure that there is enough light, that the infant is fully monitored, and that barriers are in place to minimize human traffic through the area. Ensure there is a person designated to the checklist. Ensure that there is adequate analgesia, sucrose or narcotics. Place a blue incontinence pad over the limb to prevent cleaning solution from pooling under the baby, causing chemical burns. If the infant is not ventilated, ensure some flowing gas is provided, as the infant will be under a plastic sheet for much of the procedure. Perform a timeout on the baby. Correct patient, correct procedure, correct site prior to the procedure. Before starting to scrub, open a sterile gown and towel set and place 2 sets of gloves on the open pack. Put a mask and hat on before starting to scrub. For infection control purposes, scrub the arms up to the elbows for at least 2 minutes. Keep your elbows below your hands to avoid recontamination. Using the end section of the sterile green towel, dry each hand, working towards the elbow. Note that the closed gloving technique ensures the maintenance of asepsis. Ensure your hands remain inside the sterile gown sleeves while putting on the first pair of gloves. Start by opening a sterile plastic sheet over the trolley on which to place all your equipment. Your assistant should open all sterile packs away from the trolley and then pass the items over to you. Cut a piece of sterile glove to use as a tourniquet. The no-touch technique applies to the catheter at all times. Draw up 10 ml of heparinized saline and use the 10 ml syringe to flush the catheter. Never use a smaller syringe to flush the catheter, as the smaller syringes can generate higher pressure and can rupture the catheter. Only use pulsatile actions to prime the catheter, as applying sustained pressure can also rupture the catheter. Use a sterile green drape to contain all equipment for the insertion. Also prepare a piece of duoderm by cutting a rectangle approximately 2 by 3 centimeters. Prepare steri-strips by cutting one of the 3 strips in half. Try to be methodical when setting up your equipment. Prepare the rest of the dressing as demonstrated. Note first that the procedure should be performed on an open surface. If the infant is still in a crib, it's preferable to drop the sides completely and perform the procedure through the open sides. This applies to all gestational age babies, even extremely preterm babies. Ask your assistant, who is fully scrubbed, to hold the limb with the non-dominant gloved hand at the elbow or knee. Cleaning begins at the hand or foot and progresses towards the assistant's gloved hand. Clean the area twice. Place sterile gauze over the hand or foot and allow the assistant to hold the hand or foot with the other gloved hand, while the proceduralist cleans the rest of the limb. Take the sterile plastic sheet and place it over the baby. Insert the limb through the hole in the plastic drape. If the hole is too big, use a towel clip to reduce the size of the hole to minimize the risk of contamination. Place 2 sterile cloths or sheets around the limb. And secure them in place using the towel clips as demonstrated. Now remove the first pair of gloves and place your pre-prepared equipment on the working surface for ease of access during the procedure. Always remember to use forceps whenever handling the catheter. Cannulate the vessel and remove the tourniquet. Using the no-touch technique, feed the catheter through the cannula 1 centimeter at a time. The catheter should feed easily through with very minimal resistance. Feed the catheter to the measured distance and flush the catheter hub with saline to remove the blood. Now gently withdraw the cannula and then remove the stylet from the catheter. If the site is bleeding, apply gentle pressure with gauze. Secure the cannula to the catheter hub and secure the catheter to the skin as demonstrated. Ensure the catheter is at the correct distance at the insertion site. Curl the excess catheter and secure with steri-strips. The aim of the loop is to ensure the dressing covers the whole catheter and also to ensure that there are no kinks in the catheter which could impede flow. Place the tegaderm that has the plastic patch onto the insertion site. And apply the second tegaderm to enclose the remaining catheter. Note that the team approach works very well to ensure the dressing is completed with minimal fuss. Units differ as to the methods for ensuring that the catheter is in the correct place. The main method for doing this is with X-ray with or without contrast. It is critical, however, to ensure that the tip is in the correct place, most particularly that it's not located within the heart. Some units with the necessary skills are using ultrasound for the detection of the tip. Long-axis imaging of the superior or inferior vena cava are very useful for showing that the catheter is not entering the heart. When finished, ensure that the proceduralist and assistant complete the checklist and document the insertion details, including the date, time, depth of insertion, and the site in the patient's records.